So without further ado, I'm going to introduce our first speaker, Dr. Kim. And I get the honor of trying to keep people on time this morning, but an early afternoon. We've already had one flight get canceled for one of our speakers, but that's much better than last year from the Pancreas Cancer Conference when I went home and noticed that my car had been stolen. So, but that's okay. We found it 9 months later. And hopefully no cars will get stolen this year. We'll stay on time. But Dr. Kim from St. Louis. Yeah, welcome. So Dr. Kim's an advanced gastroenterologist at St. Louis University. We're happy to have her join us. Some interesting facts about her. I learned that she's climbed Mount Fuji, and we're very excited that our relationship with Rutgers, St. Louis is really expanding in advanced gastroenterology, and we're excited to hear what she has to say.
Thank you for the very kind introduction, Dr. Page. It is my pleasure to be here. Thank you for the invitation. I think it is very fitting to be doing this talk in the beginning of November, which is Pancreatic Cancer Awareness Month. And we're going to discuss early detection that can save lives and empower individuals who have been touched by pancreatic cancer. As I was preparing for this talk, I was reminded of the impact of the work that is being done in the field of pancreatic cancer and how meaningful the impact is, not only realizing my own role as an advanced endoscopist, but what we can really do, the amazing work that's being done, not by only gastroenterologists, but also others in the fields of radiology, molecular biology, and oncology. And it's so great to see different specialists here today, people of all different backgrounds, anyone that's really been touched by pancreatic cancer. I also especially want to thank the cancer survivors that are here in the audience today. Thank you for sharing your stories with us. Okay. I have no disclosures. So before we jump into the nitty-gritty in this lecture, I just wanted us all to remember why we're here today, and it really is for our patients. So to start with this quote, cure sometimes, treat often, comfort always, which highlights the importance of building trust, forming relationships with your patients in order to provide the most effective medical care, not only in cancer treatments, but anytime that we as physicians are interacting with patients, we want to remember that we're treating other people. And even when we're not able to give a really kind of quick and easy and nice treatment that the patient's hoping for, just being available can be very meaningful and can really impact your patients' lives. So the outline of this presentation will include an overview of the epidemiology of pancreatic cancer. We're going to discuss pancreatic cancer screening. We will talk about pancreatic cysts, the role of cross-sectional imaging and diagnosis, the role of endoscopy, endoscopic ultrasound, EUS. And we're going to finish by comparing some different guidelines that we have available to us for management of pancreatic cysts. So what we know now is that pancreatic cancer is the third leading cause of cancer death in the United States, and on its current course, as was mentioned by Dr. Page, it's going to be the second cause by 2030. Unfortunately, most are diagnosed at a late stage, which means that less than 10% are eligible for a potential curative surgery, leaving a 5-year survival across all stages of approximately 9%. So how do we screen for pancreatic cancer? So generally, we do not screen everybody, average risk individuals. But we have developed screening strategies, such as identifying high-risk individuals that may have a genetic susceptibility, patients with new onset pre-diabetes or diabetes, and patients with possible precursor lesions like pancreatic cysts. Our screening strategies include performing CAT scans, MRIs, and endoscopic ultrasound, and identifying biomarkers that may help us look for patients that should be screened. However, despite the rigorous screening that we may undertake of at-risk individuals, this recent prospective study that was published in the American Journal of Gastroenterology showed that the yield of screening for high-risk pancreatic lesions is lower than was previously reported. So as you can see here, most patients that were screened really had low or intermediate risk findings. And ultimately, screen-detected pancreatic cancers are still unfortunately being diagnosed at an advanced stage. And in this study, specifically, there were 2 patients that were screened that had pancreatic cancer, and one of them was already at a stage 4. So there are certain genetic syndromes and genes that have a higher predisposition to develop pancreatic adenocarcinoma relative to an average individual. So here you can see that certain genes and syndromes, what the relative risk is to develop pancreatic cancer in the first column. Then in the next column, we see a lifetime risk, and as well as the certain specific genes. So now to go over some recent guidelines from the American Society for Gastrointestinal Endoscopy, which offers suggestions based on, unfortunately, very low quality evidence in most of the recommendations, but generally recommends screening individuals with a genetic predisposition with either EUS alternating with MRI, or MRI based on patient preference, available expertise, and for all individuals that are considered to be at an increased risk based on genetic susceptibility. So the guidelines further specify screening individuals with a BRCA1 and 2 variant to begin at age 50 or 10 years earlier than their youngest relative with pancreatic cancer, and to continue screening on a yearly basis. It is similar for the PALB2, FPC, ATM, and the Lynch syndrome with first or second degree relative with pancreatic cancer. For the FAMMM syndrome, screening should begin at age 40, as well as for the autosomal dominant hereditary pancreatitis. And for Peutz-Jeghers syndrome, screening should begin at age 35. So now we will shift gears a little bit from hereditary or genetic predisposition, and we're going to be discussing potential precursor lesions to pancreatic cancer, such as cysts. So we're going to start with a case study. So let's say we have a 68-year-old woman, and she's presenting to the emergency department with hematuria. So she has blood in the urine, and of course she's in the emergency department, so she's going to get a CAT scan. So the CAT scan shows this cyst that is sitting on the pancreas. What should we do next? So do we recommend that she has a repeat CT scan, maybe at a short interval, maybe in 6 months or 12 months? Do we try to look at the cyst in a different way, maybe get an MRI or an EUS? Do we specifically request an EUS with fine needle aspiration or FNA, or do we refer this patient to a surgeon? So this is a typical presentation for pancreatic cysts, as most of them are discovered incidentally when patients are usually getting cross-sectional imaging for a different reason. And usually patients are asymptomatic in regards to the cyst. So the most important thing is differentiating benign cysts from cysts that have a malignant potential. So pancreatic cysts are reported by radiologists in about 15% of radiographic studies. Fortunately, most of these cysts are benign, and in the vast majority of patients, they won't progress into cancer. So it is our job to figure out accurately who is most likely to progress and intervene at that point where we can get a curative resection. We know that the prevalence increases with age. So if you are 80 years old, there is a 1 in 2 chance that you may have a pancreatic cyst. If you are 70, there's a 1 in 3 chance that you'll have a pancreatic cyst. If you're 60, there's almost a 1 in 4 chance that you'll have a cyst. It almost goes exactly in that order. So if you're 50, there's a 1 in 5 chance that you may have a pancreatic cyst. Okay, so pancreatic cysts are common. Well, how likely are any of these cysts to actually turn cancerous? So it a little bit depends on what type of cyst it is. So there are pseudocysts, which are inflammatory cysts associated with pancreatitis. We also have these serous cystic lesions, which are essentially benign. And then there are IPMNs and the mucinous cystic lesions. And these are the ones that may have a potential to turn into cancer. These are the ones that we watch, and these are the ones that we use criteria to decide when we should intervene and perhaps remove these cysts operatively. So what we try to do when we see a patient with a cyst in the office is to figure out what type of cyst the patient may have, as well as what type of risk factors in order to determine the strategy that we're going to employ, which could just be reassurance. We could just let them know that this is definitely a benign cyst. We don't need to do anything further. Everything is fine. And they don't need follow-up, but that is rare. And we may tell the patients what kind of follow-up they need, or we may be seeing these patients and referring them directly to surgery, which is also rare. So this is a comprehensive table with specific cysts features to help us differentiate the types of cysts. For the sake of time, we're not going to go into too many details about the individual characteristics of all of these cysts, but I want to point out the serous cystadenoma, or the serous cyst that I mentioned before, that is benign. So it has supposedly this typical honeycomb appearance. It's more commonly found in the body or tail of the pancreas rather than the head. It is predominantly seen in female patients. And if you have a high index of suspicion and there's a classic appearance, then we don't need to do any further testing on a cyst like this. However, as our surgical colleagues here may know, diagnosing these is not always easy, which is why in most of the published reports of large surgical resection series of pancreatic cancer or pancreatic cysts, you'll find that 10 to 20% of the patients that had one of these serous cystic lesions that hadn't been recognized and was operated on. And had we known that, then maybe this patient could have been spared an operation. Another thing I want to point out on this slide is in the precancerous lesions, if you notice, the larger the size of the cyst, the larger the size, the higher the risk of transformation to cancer. So you may also notice on this table that we're looking at the cyst fluid. We're doing some sort of analysis. We're looking at CEA levels or amylase levels that help us differentiate between the types of cysts. So what about cross-sectional imaging? What is the role? So CT scans and MRIs have the benefit of being low-risk interventions. They're non-invasive tests. So cross-sectional imaging may not always accurately tell you what type of cyst this is, as there's only a 40 to 60% accuracy for predicting the correct histological diagnosis. However, it is pretty accurate in distinguishing aggressive from non-aggressive features of the cyst. We can also use CT and MRI for surveillance because these tests are fairly standard and they're reproducible. So we can use them to compare, the features of the cyst kind of at every interval. So when should we refer for an invasive procedure like an endoscopic ultrasound? So there are currently 5 main guidelines that are related to the management of pancreatic cystic lesions. There's the American Gastrointestinal Association, AGA guidelines published in 2015. There's the International Association of Pancreatology, IAP, or the Fukuoka guidelines that were updated in 2017. There's the American College of Radiology, ACR guidelines, the American College of Gastroenterology guidelines, and the European evidence-based guidelines that were published in 2018. So this table is indeed meant to scare and overwhelm you. I tried to summarize and compare and contrast these guidelines, but unfortunately, these are all based on retrospective studies and that do not account for most tumor and patient-specific factors, and they're based on low quality of evidence. So we do have to take these guidelines with a little bit of grain of salt, and no one's really going to tell you which one is certainly the best one. There's a little bit of a difference on opinion. But all these guidelines mention high-risk features of the cyst on initial imaging or or subsequent surveillance that should prompt you to send this patient for further evaluation with an endoscopic ultrasound. For example, if you have a patient with a pancreatic cyst that's over 3 centimeters in size, there is a solid component on imaging, and there is a dilated main pancreatic duct, that patient should proceed to an endoscopic ultrasound with fine needle aspiration. So EUS, endoscopic ultrasound, is an invasive procedure. It is an endoscopy. The way that we perform this procedure is we have a tube. It's a little bit thicker than a standard gastroscope. It has a camera at the tip, but it also has an ultrasound probe. We pass it through the mouth. We go into the stomach. From there, we turn on the ultrasound, and we're able to get a very close look at the pancreas that sits just behind the stomach, and we're able to get a really careful assessment. Other benefits of this procedure is that we can perform some interventions while we're there. So we're not just looking. So we can pass a needle through our scope. We can take a biopsy. We can extract fluid. And we can pass other instruments through our scope that I'm not going to go into too much detail about today. But the cons of using endoscopic ultrasound is that there is some inter-observer variability. And of course, it is an invasive procedure. So in all of the guidelines, the role of endoscopic ultrasound currently is really limited to evaluation and surveillance of cysts that have worrisome features or high-risk stigmata after they're identified on MRI or CT scan imaging. So even though we currently are using the EUS more for the diagnosis rather than surveillance, according to guidelines, it is possible that we may see a trend of EUS taking over cross-sectional imaging for surveillance. So this is highlighting the work of the PROCEED consortium that has started to standardize EUS findings so that we can document and follow more carefully the changes in the EUSs that we're performing year after year. This consortium proposed definitions for parenchymal abnormalities. It provided correlation with distribution within the pancreas and provided histological correlates with both benign and neoplastic pancreatic disease. So to return to the role of EUS from the guidelines, we're looking for worrisome features on the initial test that detected this incidental pancreatic cyst, and of course, on subsequent surveillance studies. We're looking for cyst size over 3 centimeters, thickened or enhanced cyst walls, and a dilated main pancreatic duct between 5 and 10 millimeters. For reference, the upper limit of normal of the main pancreatic duct is about 3 millimeters. We're also looking for solid components or mural nodules, and we look for irregularities in the pancreatic duct, such as an abrupt cutoff or a change in the duct with distal atrophy, and of course, if there's evidence of lymphadenopathy. High-risk stigmata in the guidelines refers to cysts that may have already transformed into cancer. So these worrisome features are obstructive jaundice, enhancing solid components, and a main pancreatic duct that's over 10 millimeters. So apart from the high-risk stigmata on the last slide, these are other indications that really necessitate a referral to surgery. So an elevated CA19-9, a cancer antigen, a rapid increase in the cyst size. However, it's much easier said than done. So for example, a nodule sometimes is very difficult to distinguish on endoscopic ultrasound from something benign like just mucus. So on EUS, that's as seen in these images here, this mucus at the top is hypoechoic compared to the adjacent soft tissue and has a smooth edge and a hyperechoic or bright rim, whereas the nodule is isoechoic or similar to the rest of the tissue around it and does not have that bright border. But as you can tell, it's sometimes a little bit difficult to distinguish. So what about innovations in endoscopic ultrasound? So since I'm an advanced endoscopist, this is particularly interesting to me. We have developed innovation in the ways that we can image by EUS to improve our accuracy in making this diagnosis. So EUS elastography measures tissue stiffness, and it calculates a strain ratio between normal tissue and lesional tissue. So the blue that you see is lesional tissue versus the green and red, which is normal. So the increased strain ratio has significant association with pancreatic cancer compared to, for example, a neuroendocrine tumor. In contrast enhanced EUS, this is when you give an injection of a contrast agent, which improves the mass identification using microbubbles. So the contrast agent is seen in the circulation of the pancreas tissue. So hypo enhancement, or where there is lack of it, has an 85% accuracy for diagnosing pancreatic adenocarcinoma by EUS imaging. And lastly, confocal endomicroscopy allows us to see microscopic images at a single cell level. And this is where fluorescein is administered through the IV, and a needle probe is used within the tissue that allows for detection of tissue that picks up the fluorescein tracer. As well as using this technology, we're also using near-infrared tracers to detect neoplastic tissue. So in a systematic review, the accuracy of using confocal endomicroscopy was 80 to 97.5% in detecting pancreatic cancer. So let's go back to our case study. What should be the next step? What if we choose option C, EUS? So a multi-center study in the US from a few years ago now showed that unfortunately the accuracy, sensitivity, and specificity in determining a cyst to be mucinous or non-mucinous was not good. It was only about 50%. However, EUS is helpful at looking for potential worrisome features of the cyst, such as the solid components, mural nodules, evaluating the pancreatic parenchyma, and getting more information on the cyst, such as the number of septations or potential communication with the pancreatic duct that may help in determining the type of cyst it is and its malignant potential. However, we really start to see a true benefit of EUS when we also perform fine needle aspiration during the procedure and extract cyst fluid that we can then send for further analysis. So the benefits of EUS FNA, or endoscopic ultrasound with fine needle aspiration, is that there is a high sensitivity in diagnosing malignancy related to mural nodules. There's no radiation involved. And of course, we can test the fluid's DNA, look at tumor markers, perform a cytological analysis, as we mentioned previously, also to look for specific values like amylase. But of course, an EUS is invasive, and up until the recent PROCEED consortium that I mentioned a few minutes ago, there is some inter-observer variability with this test. So in this slide, we can see what we currently test for when we extract fluid from the cyst. We check cytology, we look at the CEA level, we do a DNA analysis, we check the glucose level, and sometimes the amylase. And there are many potential biomarkers in the pipeline. Unfortunately, in clinical practice, we do not always have enough cyst fluid to run all the tests that we want. So which do we choose? What do we, tell our tech to send it for? So in this meta-analysis, cytology from EUS FNA alone was not very sensitive, although it certainly was specific. So the next generation sequencing is here, and it's already the standard of care and no longer investigational. We routinely send cyst fluid for genetic analysis that looks for a P53 mutation, KRAS mutation, GNAS mutation. These results help to distinguish the cysts from one another. For solid lesions, we have traditionally performed only histology on the fine needle biopsy specimens in order to have confirm the diagnosis of pancreatic cancer. What about using other markers to confirm the diagnosis? So the work that has been done on this goes back to the idea that all of genetic mutations within the pancreatic tumor cells, KRAS, for example, is positive in 95% of pancreatic cancer. So the idea here is to do genomic sequencing on the fine needle biopsy specimen as a marker for diagnosis and not just rely on histology. And in this study, 30 patients underwent EUS with fine needle biopsy, and a diagnosis was made in 100% of those patients. DNA was able to be extracted in 97% of those patients, and mutations were found in 94%, thus offering an improved ability to confirm a diagnosis in these cases. So despite the advances in the needles to get more fluid or tissue, improve visualization, more widely available genetic testing, we are often left with inconclusive results. And this is where the guidelines come into play in helping us determine surveillance guidelines. If we cannot specifically identify the cyst and get an idea of its malignant potential, then per the guidelines, we assume that it may have a malignant potential, such as an IPMN, and we enter the patient into a surveillance protocol. When entering the patient into a surveillance program, it is very important to have a conversation with the patient. And this conversation should include whether the patient wants to be entered into a program like this. So, once you enter someone into a surveillance program, they're going to need to be getting routine tests. So this could be emotionally stressful and taxing. There could be a financial burden. So these are things that, we should discuss with our patients. And of course, we should talk to our patients whether they would want to undergo surgery if necessary. If they're at this point in their life that say, I never want to have surgery, then there's no reason to be surveying these cysts. And of course, we need to make an assessment of whether this patient is a surgical candidate currently, because if they're not a surgical candidate right now, then there's no purpose in surveying the cyst. So now we're going to look at a few of the guidelines in detail. So this is the International Fukuoka guidelines that were updated in 2017. This includes that mural nodules over 5 millimeters as an indication for direct referral to surgery. So this is a difference from some of the other guidelines. And the highlighted areas on the slide are the updates that were made from the earlier 2012 guidelines. These are the AGA guidelines, which recommend endoscopic ultrasound if there's evidence of 2 or more worrisome features. These are also the only guidelines that recommend stopping surveillance after 5 years if there had been no change in the cyst. So in clinical practice, many of us feel a little bit uncomfortable with this recommendation, especially since we know that cancer tends to, increase with age. And so if the cyst has remained basically the same for 5 years, there have been some studies that show that it can potentially, progress later on. So these are the 2018 ACG guidelines, which have a lot of similarity to the International Fukuoka guidelines. So we're not going to go into too much detail here. And here's a specific difference in the guidelines that I wanted to highlight. For the management of the mucinous cystic neoplasms, the MCNs, the AGA and the ACG have the same recommendations as for IPMNs. However, the Fukuoka or the international guidelines recommend surgery for all fit patients with this type of cyst. So one thing that is similar across all guidelines is that if the patient is symptomatic from the cyst, then surgical resection should be offered. So, and again, as mentioned before, cysts that do not have any worrisome features in patients that are fit for surgery may enter a surveillance program. And here are some differences between the recommendations for surveillance. So now, how do we make sense of all these guidelines? So looking at the impact of guidelines, a study in 2020 developed a simulation model to evaluate the outcomes of 10,000 patients that were managed by each guideline. This primary outcome was the mortality related to pancreatic cysts. And what they found with this model is that the risk of malignant transformation was only 0.12% per year. And they concluded that a less intensive guideline will result in similar deaths to a more intensive guideline at a much lower cost. So, of course, there are pros and cons to using one guideline over another. For example, the 2017 Fukuoka guidelines are a little more aggressive and they tend to lead to more surgeries, whereas the AGA guidelines from 2015 may miss more cancer. So, I'm going to conclude with some take-home points. Screening for pancreatic cancer should be performed in all patients that have a genetic susceptibility, those that have new onset diabetes or pre-diabetes, and patients that have pancreatic cysts. We use MRI, endoscopic ultrasound, CA19-9, and A1C for surveillance. And we perform EUS-FNA for nodules, dilated duct, or masses, and when the cyst is over 3 centimeters. Cyst fluid analysis with CEA, tumor markers, cytology, and glucose should be performed. And we're going to be applying current guideline-based surveillance strategies, although all guidelines have flaws. And we'd like to look forward to new innovations, AI, precision medicine, and early lesion detection. Thank you very much for your attention.
Great. Thank you, Dr. Kim. First, any questions from the audience? See Dr. Georgievsky up there. Dr. Zabo.
Thank you for the talk. I have a question. I'm an oncologist, so we order a lot of NGS, and we also follow IPMNs as well sometimes. You mentioned that you do NGS on the fluid that you aspirate. Do you ever pair it with peripheral blood NGS, looking for circulating tumor DNA?
We generally don't, no.
Have there been any studies looking at that where they will pair the two? I'm just curious
Yeah,
because
that's a really good question. I'm not sure of any studies. We generally, the only blood test that we may get is the CA19-9,
Okay.
the glucose or A1C, but we send the cyst. So there's a few companies that will do the tumor markers for us.
right.
And so we send for the whole panel, basically.
And when you get the fluid and you do get positive findings on NGS like KRAS, whatever you send it for, you're not saying it's malignant, you're saying it has malignant potential. Am I correct?
Correct.
Okay. All right.
Yeah.
Thank you.
Yes, sir.
Thank you for the great talk. I am a patient of Dr. Page's, 9 months since detection. Stage 2, I'm right now done with surgery, 12 sessions of chemo, and I was a financial guy. I'm retired. I feel I'm very lucky. My question is the CA19-9. I'm a numbers guy. My 19-9 from biopsy positive January 9th this year was in like 3740. It's between 37 and 47. And my question is, being a numbers guy, why isn't it 0? And I'm hearing a lot of things. Well, it's really based on your chemistry in your body, and we really need to worry about it when it gets higher than that, much higher than that. If you could just give me your opinion of that test. And being a numbers guy, everybody's telling me don't worry about it until it goes way up. Thank you very much.
Sure, that's a really good question. So all the tests have some flaws, and the C819-9 is not, 100% related to pancreatic cancer. So if there's something going on in the pancreas, maybe it's a little bit irritated for whatever reason, the number can go up and down by itself. So if I was to draw my own blood today and then check a week from now, the number might differ, just, based on, maybe you ate a very high fat diet, for example, and your pancreas is working a little extra time. I don't think that we should be looking for it to go down to 0, but it is helpful in following it, especially if the number was really high at diagnosis, and then you check it again, as you're progressing through your treatment. And if the number is coming down, then it supports that the treatment is working. But it's not, super accurate, and we're not looking for it to go down to 0.
Great question. I'm going to put our keynote, Dr. Fleming, on the spot, but I agree 100%. I think CA19-9 is one of the most awkward numbers to interpret that we have, because then there's the non-secretors who have 0 all the time when they have potentially metastatic disease. And then we have the patients they get a screening CA19-9 and it's 600. What do you do with that? So my answer is, you and I have talked about this, but it's a relatively imperfect test. But I do want to hear what Dr. Fleming has to say about it.
CA19-9 question. So I agree with everything that's been said. One caveat to CA19-9 is that any liver biliary perturbation will make that number go up. So you've had a Whipple, so you don't have an ampulla, which is the valve that. Oh, okay. So even with that, if you get some, cholecystitis or anything that would inflame the biliary tree, it's going to go up. So we don't walk around checking everyone's CA19-9 all the time. Like, yeah, yeah, some people just don't. It has to do with your blood type. And so it's not if we were designing a marker, we wouldn't use that.
Dr. Sachs, anything to add?
I completely agree. I think Dr. Fleming hit it right on the head. If we were designing the marker, it wouldn't be that, but that's what we have, and so we add it to our repertoire of different tests, and then we have to interpret it cautiously.
I like to say it's part of the puzzle. Like, how's your weight? How your labs? How are your other numbers doing? But great question. Yeah. We have time for yes, ma'am.
Hi, my name is Deborah Davis DeWitt. My husband passed away of pancreatic cancer 2 years ago. And the first bullet point you had for take-home points was that to screen for pancreatic cancer, patients would have to have a genetic susceptibility, new onset of diabetes, or prediabetes, or pancreatic cysts. For my husband, that wasn't the case. So my question is, what would I do? And I know it's a tough one.
So unfortunately, most of the patients that are diagnosed don't go through one of these, right? So they're just sporadic. And I unfortunately, I don't have a really good answer for you. Yeah.
Yeah, the sporadic de novo pancreas cancer it's incredibly frustrating. I can't imagine. I mean, I'm sorry for your loss.
Yeah. Yeah.
Yeah, Jason.
So those numbers that she's showing are relative risk numbers, right? So there's like a baseline risk that living in the US you have, and but those are far and above. Some of those are 100, 50, 132 times is what that means, which is crazy high, right? But that's a really small group of people. The one, and I'll talk a little bit about this, that one, the hereditary pancreatitis is a really interesting one. That's inflammation. Those genes aren't cancer genes. That PRSS, those are inflammatory genes. And I think, so people talk about diet-related inflammation, inflammatory changes, gallstone disease, all that stuff is in the mix. And so it's hard, we don't have it quantified yet.
We got time for one more in the back.
Yeah, perfect. One more.
Dr. Kim, you mentioned that you get information when you do the needle biopsy during EUS that helps you confirm a diagnosis. Is any of that genetic information also helpful in determining treatment response?
So the genetic information that we're getting from the cysts is more is not this. It's not the genes that someone may have to increase their predisposition to getting cancer. What we're testing for, the tumor mark or the genetic test that we're doing, really just help us differentiate between the types of cysts. So if we, for example, have a cyst and we're just not sure, it doesn't have a typical appearance. And then we send the fluid off and the results come back and point us that this might be a serous cystic lesion, like the one that we were describing, having that honeycomb appearance. Then that tells us, okay, this is a benign cyst. We don't need to put this patient through a surveillance program. So when we're doing the tests on the fluid, the cyst fluid analysis is more for differentiating the type of cyst and then placing that patient into a surveillance program or referring them to surgery. Like if we do a cytology on there and it shows that there's already some cancer inside the cyst, then we might refer them directly to surgery. If it shows us that this is a benign type cyst, then we basically say you don't need any surveillance, but it does not guide treatment.
Great. Well, thank you. Actually, I think that was a great talk to start with because it's covering a lot of what our subsequent talks are today, especially on the genetics angle that Camille's going to be talking about with us later. But thank you, Dr. Kim.